This is actually one of my first cases when I started here as faculty. From actually end of December and followed into the next year. So I put the title a little vague, management of carotid artery injury. This is the EMS report for the code 1 that I received. It was a 28-year-old male, reportedly MVC, restrained driver, self-extricated, speed was unknown. There was definitely damage to the car, the front of the windshield. They found him down next to the car with some dry blood on his face. He was hypotensive in the 90s with a GCS at 12 given in the field. They put a C-collar on, started on IV fluids and peripheral IV. When he arrived to our trauma bay, his airway appeared protected and he had bilateral breath sounds. However, he was not looking good, tachycardic and hypotensive. So I activated MTP. I gave him a GCS of 9, but I just made the decision to intubate him because he just didn't look good. As we were preparing for intubation, quickly exposed him. Other than a little bit of blood on the dry blood on the tongue and nostrils and around the mouth, there were no other findings. We also had time as we were preparing medications to get a quick chest X-ray, which you can see looks pretty normal. The pelvic X-ray also looked okay, and a 4-view pericardial, a 4-view fast was negative for fluid. As we were working on intubating, obviously intubation was unsuccessful, oropharyngeal intubation due to poor visualization and a lot of blood in the oropharynx. So I performed the surgical airway. And you can see here now the chest X-ray showed the number 8 ET tube that ended up being a right main stem. Look at the size of the heart compared to this other X-ray, definitely, you know, some major bleeding somewhere. And now there's blood gushing through the nostrils and through the mouth. What basically ended up doing was pulling the ET tube, and as I was packing the mouth, I just saw maybe like a little puncture wound here that was kind of suspicious behind the ear. And surprise, surprise, after the ET tube was pulled back and with a lot of packing, repeat chest X-ray shows basically what you see. So what would you do next? If you go to the operating room, what incision would you make? What are your thoughts?
Dr. Super, Bangkok, your comments, please. Sorry about that. I didn't know you were eating.
I'm okay to discuss now.
Okay.
For this patient, he has lots of bleeding from his mouth and nose, had transcervical gunshot wound. It would be difficult to go to the OR straight and try to stop the bleeding from the mouth. I think I would give him some fluid and blood and see how he does. If he maintains his vital signs, I would send him for a CT angio of the chest and neck, because sometimes a bleeding from the branches of external carotid artery can be managed by embolization. Thank you very much.
Thank you, sir. Dr. Kasim, Portland, your comments, please.
Alex, the wound you're seeing, it is, could you describe that one more time, the size?
So the X here on the X-ray is basically right here behind kind of the earlobe, close to the mastoid. So it's basically, zone 3.
The internal carotid.
Zone 3.
And
so it's
traversed across, and I found the bullet on the right side on the X-ray.
Right.
And this was
okay.
An MVC.
I think it'll be difficult for you to control the bleeding per oral. So you have to devise something that you want to do to stop the bleed. Of course, that will be the main concern here before you do anything else after the airway has been established, which you have. So I think I would probably deploy either a Foley catheter or a Fogarty catheter through that hole and see if I can somehow get the balloon deployed and see if that helps me in clearing the airway, clearing the blood from the mouth, so I can visualize something more and also stop the bleed. At least I will try that. If I'm not successful after a very short period, not going to be spending a lot of time doing this. And I think the next step would be to go with the patient to the angio suite for a CTA. I think I will go with him with all my equipment and everything available should I encounter some type of a drama in the CT angiogram. I think that's how I would manage this dying emergency right now. I think my goal is to stop the bleed and get an angiogram done and then go from there. Thank you.
Thank you, sir. Baghdad, Dr. Muntrat.
Okay, so I take it then there were no hematoma on the left side, but in the mouth he was bleeding from the left side. Is that right? Or couldn't you tell, Dr. Alex?
I couldn't tell. It was just gushing out of the mouth and nose.
Out of the mouth, but okay, and the right side of the neck looked normal, and no thrill, right. So just an observation. This kind of is a little bit reminiscent of the injuries that occur occasionally in kids. I remember from pediatric surgery after a tonsillectomy, a patient came to us gushing blood, the same sort of phenomenon by just the operation of removing the tonsil caused bleeding from the carotid or a branch of the external carotid through the mouth, and then what to do about it in this case. I really, after hearing Dr. Supa and Dr. Qasim, I certainly would not differ with what they say, and I think probably I'd be inclined, what Dr. Qasim said, try to stop the bleeding with a balloon, and then after that go to angio and see if they can control it in angio. And then the other option is to put your finger in the mouth, get control, direct digital pressure from through the mouth transorally, and then go right to the operating room and expose the carotid and get proximal control if you can in the neck. But I would first start with the two suggestions, Dr. Qasim and Dr. Supa, the balloon tamponade, and then angio.
Thank you, Dr. Muntrat. Boston, Dr. Hoyman.
These type of injuries are some of the most frustrating for us trauma surgeons, because we can see the bleeding and we cannot access the area of bleeding. So it's incredibly frustrating to have these cases, because the bleeding is just there in front of your eyes and is at the same time inaccessible. I would take this patient for an angio. I would go with this patient to the hybrid room. It all depends how hemodynamic. I would try to pack, but depending on that, he will go to the hybrid room, and it will be a combined procedure with radiology, shooting the angiogram, see if it can be embolized, and probably ask, based on the location of the bleeding, where to go. Because despite the college requirements that the radiologist be present within 30 minutes, whatever, I know it will take some time to get the angio suite set up. If I can, and if the patient allows me, I will try to do a quick run through the scanner to see if I can identify, because this patient can be bleeding from the left or right, you don't know. Based on the location, many vessels at the base of the skull can be injured based on in this plain film. So I will try to identify the source of bleeding just in case the radiology is not on time, so I need to proceed with surgery and try to control with surgery before the radiologists get here. Zone 3 are notoriously difficult. If it's either carotid or jugular vein, they are both very difficult to control in that area. The carotid in particular is at the base of the cranium. I probably would not put a Foley balloon blindly. I would probably make an incision and try to identify the carotid. And
You cannot do that in that area.
Distally and try to control proximally with clamps. But this is very difficult because you really do not know which side is bleeding from where. So this is angio if you can, and CTA ideally before you operate. Otherwise, you are stuck as a 50-50. You're flipping the coin. You go to the left thinking that the bleeding is there, but maybe the bleeding is on the right. So all the incisions are at this time kind of bad incisions until you can determine where the bleeding is coming from. Thank you.
Thank you, sir. Dr. Byers, you have comments, ma'am?
Yeah, I have some comments. First of all, I think that's important, as everyone has mentioned, to figure out which side the bleeding's coming from. And it seems like if the blood is gushing out of the mouth, it's bleeding into the mouth. So perhaps you could pack one side really tight and see if, and then look, obviously you'd need help with this, but that's one thing I would do. Second of all, based on the title of the presentation and based on the amount of bleeding that you're describing, I think we have to assume that this is a zone 3 carotid artery injury. So I think you would have to, this is very difficult to access surgically. So you would need to get either radiology, we have to get neurosurgery. I think a hybrid OR would be perfect, but you would have to get OMFS because if you're going to get operative exposure of this, you have to actually take the mandible, dislocate it and move it forward to be able to get control of this artery in that location in the OR. So basically that's what I would do, try to figure out which side it is, and then proceed to, if you had a hybrid room, that would be the perfect situation, and have people that could come put a stent in if possible.
Mm-hmm. Thank you, ma'am. Dr. Calderon, your comments, please.
Yes, good morning. First of all, good catch, because I was still thinking this was another blunt facial injury. Now I see clearly it's a gunshot wound to the neck and the face. And that's tough because I have to figure it out, where is it bleeding from? Well, of course, you already secured the airway. We're giving resuscitation to the patient. And now I have to figure out where is it bleeding because I need to know where do I have to operate it. I don't know, it's a vascular injury in the neck, or it can be a bleeding pharyngeal injury too, or tongue injury. So if the hemodynamically status of the patient allows me, I will need imagings just to take a look at I will need a CT angio of the neck, see carotids, and if I can, see the jugular, or maybe it's, as I said, maybe a pharyngeal injury that it can bleed a lot too. That's all important because I will need to know what approach to do for these patients, I may need maybe the backup from a vascular surgeon, or maybe we have head and neck surgery to help us out. Well, if I have an hybrid room, that would be wonderful. What if I don't have the hybrid or the radiologist is not coming in the next 30 minutes? That would be more challenging. Well, I will need the imagings, and with that, to figure it out what would be my next step in repairing where it's bleeding from. Thank you.
Thank you, Dr. Calderon. Is Dr. Ginsburg still with us? Dr. Ginsburg. Dr. Ginsburg? Okay, no Dr. Ginsburg.
Gary, can I?
Yes, sir, absolutely. Go ahead, please.
Say one more thing.
Please, by all means, go ahead.
The gunshot wound is coming from the left and there's a circle on the right. So I am assuming the entry is on the left. And I think the dictum in surgery, if you see something that looks like a horse and it has stripes on it, it is a zebra. It is not a horse. I think I would probably assume the bullet wound that went from left probably injured the carotid artery and causing all this bleeding. And I think that is where I would put my money in. Thank you.
Thank you, Dr. Kasim. Any other comments before we return to Dr. Alex? Okay, back to you, Dr. Alex.
Thank you. Thank you for the comments, and for the insight. So I packed a lot of quick clot. I've never packed that much in my life, but it helped. It stopped the bleeding. In retrospect, I think, if both carotids would have been injured, he would have not have any GCS at all. So one was injured, but the question is which ones, and that's what I had the hard time with. Let me try to go back. Okay, so the detective arrives with some additional information in the picture, the windshield with the bullet in it. With the packing and the MTP, the patient is not tachycardic anymore, and he's holding the blood pressure. His lactic acid is 11, and I took him for a CT angiogram of the head and neck, and I'm going to show representative slides. Basically, left common carotid here, the right common carotid is here. This is the right internal jugular vein. This is where the left internal jugular vein should be. It's all gone. We can see the bifurcation of the common carotid and the internal carotid and the external. And we can see the left internal carotid, but then it disappears here. And the external is also gone. On the right side, there is artifact. And continuing up to the base of the skull, we can see the internal carotid here, but it's gone here. We can see the right internal here in the petrous portion of the bone, and it's all gone here on the left, so thrombosed all the way up into the brain. So the left carotid is gone and thrombosed. But the right internal carotid has flow. So the CT angiogram shows basically after absent flow in the left internal carotid, transection of the left internal carotid to the C2 level with thrombosis of the left internal carotid all the way up into the brain. So how would you like to proceed now? Is there any role for going to hybrid room? If you go to the operating room, what's your surgical approach?
Dr. Calderon, your comments, sir.
I guess the angio, the hybrid room will be a better idea. That's on almost near the base of the skull. That's a very difficult site to approach. Yeah, thank you. That's all by now.
All right, thank you, sir. Dr. Wyman, Boston?
Well, this is the CTA in this case was extremely helpful because it all depends if the patient is more or less hemodynamically stable or not. Obviously, he's not, but if he's more or less hemodynamically stable or not. If it is more or less hemodynamically stable and I'm managing to catch up with the transfusions and with the packing, whatever, I would probably call, we have a very good service of neurovascular radiology, and I will ask these guys if there is any way that they can embolize the distal carotid, put a stent. Most likely not, but I will ask them. If the patient is bleeding, and he was bleeding, you at least know that it's not bleeding retrograde from the internal carotid. It's bleeding forward from the transected carotid. So that I can get vascular control. I will go with an incision anterior to the left sternocleidomastoid muscle and get proximal control and see what happened. The distal is thrombose. So really not too much that I need to do right away. I need to control the bleeding and sort the things out afterwards. The classical teaching is that 1/3 of the patients will have would basically necrose the whole hemisphere, that 1/3 will have some sequela and 1/3 will be asymptomatic. If this patient was moving everything before, and this was probably thrombosed already, probably this is a patient that you can safely ligate the carotid. I will try to look at the CTA to see if there is flow to the left side of the brain from the right side. And probably you can ligate the carotid and get away. But I will do this after I exhausted all possible options to get some time of better control after discussing with neuroradiology. Thank you. And the procedure will be done in the hybrid room, because we can do everything in the hybrid room, the surgery, the interventional neuroradiology. Thank you.
Thank you very much, sir. Dr. Kasi?
I think most of you will not have the luxury of a hybrid room. So let's talk about it, how you would do, either if you're in a community hospital or if you're in a hospital where hybrid room is not available. If there is a hybrid room is available, I would follow the algorithm as outlined by Professor Hoyman from Boston. Suppose it is not available and you are stuck with this case, you have to have a plan what you're going to do. So having determined the carotid is gone, the jugular is gone, and you have stopped the bleeding for the time being, and he's somewhat recovered from his hypotensive episode, and you have packed it with quick clot, probably use a ton of it. You have to have a method of saving this patient's life in a setting that maybe austere, maybe not. So you need to know what you're going to be doing to stop this. I think you have very little chance of doing anything like dislocating the mandible, exposing the carotid at the base of the skull. I think those are not going to be very useful to you. I think practically speaking, I think you'll be looking at ligating the internal carotid artery and to see what happens. And like Dr. Hyman says, 30% of them will have a stroke, and the other will either get better or have residual problem and get better later on. But at least you have stopped the bleed and saved the patient's life. Thank you.
Thank you, sir. Dr. Untract, your comments, please.
Yeah, so I basically agree with Dr. Oyman's analysis, and this is a typical case, internal carotid injury with no back bleeding, and then the dictum there is that that just ligate the proximal internal carotid because you don't know how long the patient is gone with absence of blood flow to that hemisphere, and if you reestablish flow, will you turn a dry infarct to a wet infarct. So I agree with what Dr. Oyman said. Basically, just ligate the proximal internal carotid, but I would also or do it in the angio suite with a coil. But I would also perhaps ask the neurovascular surgeons what they thought, whether this is in a young man like this, if there's some flow and there's no evidence on the CT of an infarct, and there's enough collateral flow across the circle of Willis to keep that hemisphere alive, whether there'd be any place for an extra anatomic external internal carotid bypass or whatever they would do. But that's the approach that I would take. I would do what Dr. Oyman said, plus ask an opinion of the neurovascular surgeons.
Thank you, sir. Dr. Supa.
This case, I think first priority is to control the bleeding. If you control the bleeding by aggressive packing in the mouth, I think that's good enough for the patient to stop the bleeding. But if we could not control the bleeding by packing, you have to do something. And I agree with Dr. Hotman to to call the neuro intervention people to help us. If they can help stop the bleeding by putting in the stent or even embolize it, that would be great for the patient, because to get surgical access for the distal internal carotid artery, like this patient, it would be difficult to do it surgically. So first I try to stop the bleeding. If the bleeding is stopped by packing, that's okay. And then I'll call the neuro intervention people to try to help fix the vessel. I think the best thing is to try to both stop the bleeding and restore the blood flow to the left hemisphere, because he's young, and like Dr. Hushman said, if the flow is disrupted, the patient will have lots of sequelae. So the best thing is to ask them to try to both stop the bleeding and restore the blood flow by putting in the stent, if possible. But if not, in the worst case scenario, I agree with performing the surgical approach for this patient. Try to identify the left internal carotid artery and try to either repair or ligate it, depending on the exposure you obtain and your experience. And we may have to dislocate the left TMJ joint to get the better exposure of the distal internal carotid artery at the neck. Thank you.
Thank you, Dr. Supa. Ryder, Dr. Byers? Doc.
So I totally agree. I think whatever's happened to this patient has happened. I think that, you know, if you wanted to repair the vessel, clearly you'd need to dislocate the jaw to be able to do it. However, the carotid distally is already totally thrombosed. So if you were to get more proximal exposure to the internal carotid, you probably wouldn't have any back bleeding. And I think at this point, it's been probably, I don't know what the time frame is, but it's been a while between the crash, self-extrication, fire rescue, packing, CTA. So to me, I think it would be dangerous to revascularize this vessel or do anything more than just ligate it or thrombose it with, you know, the neurovascular radiologist. I mean, it is what it is at this point.
Practically speaking.
Thank you very much, Dr. Byers. Any further comments before we go back to Dr. Alex? Okay, back to you, Dr. Alex.
Thanks again for the comments. So I called the NT to be available in the operating room, anticipating that we may need to do you know, a dislocation of the mandible. We called neuro IR, as everybody mentioned, because it was just transected. Their concern was that they may not be able to just go up with the wire because it was a clear transection. Vascular team was called as well, and we all went to the operating room. Basically, we performed a left neck exploration. The left internal jugular vein was ligated. Proximal distal control basically was just the left, you know, common carotid that we got proximal control. The arrow here shows basically the stump of the internal carotid on the left, which we ligated. There was no back bleeding, and there was really nothing to, you just retract it up. There's nothing to see, as if you didn't have an artery there. This is a vessel loop on the external carotid. The ET tube was converted to tracheostomy. We looked at the esophagus. Everything looked good. So we basically ligated the left internal carotid. So no back bleeding, and just the fact that it was thrombosed all the way up into the brain, it was decided that it's probably not going to help matters here. After talking with vascular and neuro IR. Now, from the CT scan, I know this guy has a stomach full of air and blood, and I was trying to unpack the mouth, and now blood is gushing again. For the interest of time and some other slides I have prepared, basically what I ended up doing is I just pulled on the vessel loop on the left external carotid, and the bleeding stopped. So ENT performed a direct laryngoscopy. They were not able to see any active bleeding other than the hole on the left through which blood was gushing with the vessel loop released on the left external carotid. So the vascular ligated the external carotid. We couldn't go to IR because at this point we had this patient with retaining CO2, acidotic. So we really had to put an NG tube quickly or do a decompressive laparotomy. So then after the left external was ligated, there was no more bleeding. The mouth was dry, and we got immediately 2 liters of air. His abdominal distension improved significantly. His started clearing up his CO2, and his pH started improving. We went to the ICU with him. We ended up doing a bedside decompressive laparotomy because he did not improve his ventilation as we were hoping. And now we are basically day 0 in the unit. We did a CT of the scan, and it was mentioned he basically now has a pretty dense stroke on the left. He also got an echo that shows a right ventricle clot. He got an ultrasound of the lower extremity showing right popliteal DVT. So how would you manage this case, this point? Anticoagulation, what are your thoughts?
Dr. Byers. Is Dr. Byers still with us? Okay, let's go to Dr. Untitled.
Well, so anticoagulation, if you have control over the bleeding and there's an ischemic stroke on that side, I suppose if the neurosurgeons didn't object, I think that would be an option. But the ventricle clot, I'm not sure about that. I'm not sure what the pathogenesis of that. Maybe I'm missing something, but I don't know. Why would there be a clot in the ventricle? I'm missing that. I don't know. The ventricle is beating, so it's not like atrial fibrillation where if you have an atrial clot, you can anticoagulate, and if there's a right ventricle clot, so he would get a big pulmonary embolus. I'm at a loss for that, but I think if there's a popliteal DVT, you could put a filter in. Although at this stage, I think he's got bigger problems. So I'll leave it for the others. This is it's a tough situation.
Thank you, Dr. Untitled. Dr. Kassim, your comments, please.
This is a very difficult problem because you have multitude of things going on, and doing one good thing will cause harm to the other. This is an ischemic stroke, and if you deploy a full anticoagulation, you will be converting this into a wet hemorrhagic stroke and brain swelling and all that thing. If he did not have a ventricular blood clot, I think I would probably put in an IVC filter and not anticoagulate him. But now that he has a clot in the left ventricle, I have to think about it. How am I going to stop this clot giving rise to significant pulmonary embolus from which he could die or he could survive? A very difficult problem. I think I probably will have an immediate conference with multitude of people to come up what I'm going to be doing here. It won't be just all my thought. I don't know. I don't know what I would be doing. I probably will get wisdom from people like Ginsburg and Byers. Thank you.
Thank you, sir. Bangkok, Dr. Supa.
If you think that the bleeding is well controlled at this point, I think he would benefit from anticoagulant because he had lots of clots in the leg, in the right ventricle, and he had ischemic stroke, which may get worse. If the flow not improved. So I think that I would start heparin on this patient. Thank you.
Thank you, Dr. Supa. Boston, Dr. Oyman.
Well, I would consult with neurosurgery, although I probably know the answer. They will tell me that the patient cannot be anticoagulated. So, because of the risk of hemorrhagic conversion. So if that's the answer that I will get, if I can anticoagulate, I will anticoagulate, obviously, but I had a feeling that they will say no. So I will, for the popliteal DVT, I will put probably an IVC filter. The echo is kind of surprising. First, I would like to know how big the clot is. Probably it's not too big. So even if we were to move, it will not have serious consequences. There are some recent papers suggesting that in trauma patients, the pulmonary embolism appears to form de novo within the pulmonary circulation. Maybe this is what is happening here. It's not a clot that traveled from the lower extremities or the pelvis, but something that formed de novo. I don't think we have enough information to make, in terms of pathophysiology, to make an informed decision. But if you are between the proverbial rock and hard place that you cannot anticoagulate and the patient needs anticoagulation, I think the reasonable compromise is to put the AVC filter and deal with some of the clots, even though you cannot manage all of them. Hope for the best, and usually in a week they allow us to anticoagulate and anticoagulate them. Thank you.
Thank you, Dr. Oyman. Dr. Calderon, my apologies. I think I missed you last time. Your comment, sir?
Yes, I'm sorry. Maybe I missed some of the information. I have a bad connection.
Okay.
I think that's a popliteal DVT and a stroke, and well, there is right ventricle clots, maybe a PE. Well, I'm asking. Well, we have to figure out if the patient is able to receive anticoagulation, we can give full anticoagulation. If we cannot, because maybe there is another risk of bleeding of the hemorrhagic of the risk of hemorrhagic conversion of the stroke in the brain, well, we will have to place the IVC filter. And maybe, well, I need to know how does the ventricular function looks like also, because maybe if there is a big, if we have, I don't know if you already did a CT angio of the chest. If we have a pulmonary embolism and we cannot anticoagulate, I'm not a fan of interventional radiology, but I know they can remove the clot endovascularly. But that's all I have by now.
Yeah. Thank you, Dr. Calderon. Let's see if Dr. Byers is available. Dr. Byers? Okay. Dr. Byers, not available this round. Any other comments before we return to Dr. Alex? Okay, back to you, Dr. Alex.
So on the initial CT scan, he did not have what looked like a PE. The combination of aspiration and everything made it a little more difficult, to say this is a pulmonary contusion from the car accident and led to, clot formation. I think probably just like a, thrombotic state that resulted from the lack of flow to that part of the brain and just trigger all this coagulation cascade, possibly also from the MTP and the one-to-one resuscitation. I don't know, but
Can I comment? I'm sorry, I couldn't get the screen on fast enough to answer.
Yes, ma'am. Sorry about that. You mind holding a second, Dr. Alex?
Okay, so I just wanted to say that I agree that you're in between a rock and a hard place, but I also agree with putting an IVC filter to stop any more clots from going forward. And I personally, you know, it's no evidence, but if neurosurgery would allow it, I would try to do 500 units an hour of heparin just to stabilize, and then put the cardiothoracic service or IR, whoever does it, on notice that if he gets a massive pulmonary embolus, he's going to need the Trendelenburg procedure of some sort. And then hope that it stays stable, like someone else said, for a week to start anticoagulation after that.
Thank you for your comments, Dr. Byers.
So we did reach out to cardiothoracic team. We asked if they can just go minimally invasive with this, you know, angiojet and just kind of just get the clot out of the ventricle. They said that usually done with some, you know, thrombolytic medication, and they don't want to make the clot worse. So we consulted also neurology, neurosurgery, and as you anticipated, the thought was to just, you know, not anticoagulate because the risk of bleeding. So it's kind of left to us. So basically what we did, so we're now in the first week in the unit. He's following commands with all this. So we put an IVC filter. We started him on baby aspirin. By the end of the first week, his belly was closed, and we started low dose heparin drip with the PTT goal of 40 to 50. And the only thing we had was to just kind of repeat the echo and see if, you know, the clot gets bigger, and just, you know, check pulmonary pressures. After that, we repeated the CT scan of the head, and the stroke remained the same. We also did a brain perfusion scan. We did repeat the echo, as I told you, and then at some point we thought the RV clot dissolved and disappeared, but it remained small. But we scanned the chest, and it definitely was wishful thinking, and just ended up being a PE, but it wasn't without any significance for the patient. But at this point we're over a week, so we did the PTT goal 60 to 80. We treated him with antibiotics for pneumonia, and his 2 Fs were at goal. And by the beginning of the 4th week, he was able to be transferred to the telemetry floor. He had a couple more bumps in the road with the pneumonia and all that. He developed a right hydrocele, for which he got a pigtail. Then he developed out of a sudden a less spontaneous pneumothorax on post-op day 40, for which he ended up getting a couple of chest tubes and a VATS. His prior CT scan showed some blebs, so those were resected. He basically continued to work with physical therapy and speech, anticoagulation at this time, which were now a month and a half. He was on 5 milligrams of Eliquis, on baby aspirin, and with an IVC filter in place. On post-op day 52, he was discharged to rehab. He was decannulated in March, and close to the end of April, his pec tube was removed. He is supposed to come to the clinic this month for additional evaluation and probably repeat imaging. He is able to show thumbs up with the left hand. I don't know, in this world of being able to have a life when you're just on a tablet or on the phone, he definitely probably has some quality of life. But on the right side, he has a dense stroke, and he's not moving anything. I just want to show a couple of things I looked at before I turn over to final comments. So the only papers I was able to find on transcervical gunshot wound was a series from Hirschberg in '94. There's a retrospective study of 41 patients they had, and 52 had major injuries, most of them being vascular, and 13 were airway. Basically, out of the 30 SIGNEC exploration that he performed, 86% were positive for cervical injuries, and 16 of these patients, so a third, required bilateral exploration, and they had pretty high mortality. The conclusion from this study was that for transcervical injuries, there's a high incidence, obviously, of major injury, and to have a low threshold for bilateral neck exploration. Dimitriades in '96, 2 years later, did a series as well. 33 transcervical gunshot wound, 24 patients, basically 73% have cervical structures that were injured. This is from a total of 97 patients in their series. Again, majority of the injuries were vascular, then followed by spinal cord injury and aerodigestive 6%. Only 21% of these patients had therapeutic operations with much smaller mortality. So the conclusion of this study was maybe mandatory operation is not necessary on all the transcervical gunshot wounds, but again, depends on everything, what the injuries are. If it's more vascular, but it's vertebral, that may be amenable to embolization. You may not need to go to surgery. So I think where I'm at, I'll probably definitely explore this, especially with the case I had. Bilateral exploration may be difficult with 2 incision, but I would probably make a collar incision that would give me the flexibility to run and be on both sides. With regards to the C-collar, I think EMS initially thought this was blunt from the car accident, and they put the collar, and probably the collar shouldn't have been on. I don't think that would have changed what we did in terms of being aggressive. This guy doesn't look good. He needs an airway. Something is not right. But again, if the perforation of the gunshot wound is not hiding behind the earlobe, and it's pretty obvious, take the collar off, because according to this paper, really the chance of having an unstable spine is less than 1% in the penetrating trauma with the more prevalence of gunshot wound compared to the stab wounds. So what if the left internal carotid was not thrombosed? So how do I access this above the level of the C2? So I always heard about mandibular dislocation, but really how exactly that's done, we were always taught to call ENT in the operating room, and then you dislocate that, and then you repair with saphenous or PTFE conduit, and then just look up some vascular papers, and there is a description of a bypass between vertebral artery of V4 with the internal carotid. So this is from a vascular surgery, 115 patients that underwent carotid endarterectomy for high disease, so zone 3, and basically how they did the mandibular dislocation was basically, I'm using the pictures of this other paper, but basically you wrap wires contralateral of around the bicuspid teeth on the mandibular and the maxillary side, and then you kind of tie them together. That leads to dislocating the mandible. If they don't have teeth, you can put the wire around the mandible, or if not, you can put the Steinmann pins in the mandible and maxilla, and then just tighten the wires around the pins to dislocate it. This basically gives you a good exposure of the carotid, internal carotid above the C2 level, additional 1 to 2 centimeters, according to this first paper that I showed you from '95 on the vascular surgery. There's no significant post-op complications from the dislocation. However, it needs to be done correctly, because nerves can be injured, and the capsular ligaments and lateral ligaments can be torn. So definitely have IR for this. ENT. And the patient needs to be nasotracheally intubated in order to do this. Lastly, and I think we'll have also time for comments, vertebral artery, we know, has 4 segments. Really, the 4th segment here, at the base of the skull, entering through the atlanto-occipital membrane to form the basilar artery. was this. I found this in a vascular atlas, basically. Not for a trauma patient, but let's say maybe you have this ideal patient where you could actually do this, Berger, was described by Berger, park bench position, where you can access the V4 segment at the level of the C1 as it enters the base of the skull. This is described for elective cases, and nowadays is the territory for the neuro IR. Basically, you can see here on the left side up top, you actually even have to divide the trapezius at the base of the skull, the splenius, capitis, semispinalis, all these muscles. And then you can see, but you can looking down at the bottom of the picture on the left side, the C1 transverse process. Once you find that more posteriorly from it, there is described this big plexus of veins that need to be ligated, and then you can get access to the internal carotid over there. And then more anteriorly, then you have the internal carotid as well. You can use that incision going more anteriorly. So maybe a distal internal carotid already bypassed from the vertebral. I personally have never seen this any place I've been and on all the vascular surgery services, but I thought I mentioned it. So thank you for your attention. I welcome any comments and questions.
Thank you, Dr. Alex. And Dr. Super, your final comments, please.
Thank you, Dr. Alex, for presenting this case. This is a very well managed and very interesting injury. And to do the bypass of the distal carotid artery, like you show in the slide, I think that would be maybe too much for trauma surgeons, and should not be able to perform that procedure in an acute trauma patient. But very interesting. Thank you.
Thank you, Dr. Soup. Dr. Kasim, your final comment, sir?
Well, we have come a long way from Andres Perry, who first ligated the carotid artery in 1550s. And we now have IR to help us out in various type of critical injuries like this at the base of the brain, base of the skull. But Alex, thank you so much for educating us today. I enjoyed your the last 5-10 minutes of your dissertation. Very, very, very interesting. It is a very interesting case that every surgeon needs to have under his armamentarium, because you might be exposed to this when you are in austere situation like Dr. Untrak is at this moment, and you might be able to save a life. Thank you so much.
Thank you, Dr. Kasim. Dr. Untrak, your comments, please.
Yeah, so it's somewhat frustrating, the misery inflicted. A young guy, 28 years old, totally gratuitous. It's, it's just something that didn't have to happen. But I compare this, though. There was a case, I think, in Miami, another one presented from Brazil. A young woman about the same age, shot, and the bullet bounced off of her cervical spine, and she was brain dead. So, in comparison, I guess maybe this young man is going to be very grateful. And from the picture, it looks like he has a dense hemiparesis. How about difficulties with speech or hemianopsia? Any of those? Do you know? Can you fill us in?
He has difficulty with speech, and his speech is working with him. He is not speaking sentences, but he follows commands, and he could certainly use and type on a phone or tablet.
Yeah, so I suppose he may, he may be grateful for what he has, but it's really frustrating, something like this. In Philadelphia, it can happen to anyone driving down the street. It's just horrible. There in Los Angeles, the 6-year-old was road rage, shot through the back of the car and killed, 2 weeks ago. So it's just sad to see these cases, really.
All right. Thank you, Dr. Untrad. And Dr. Hoyman, your final comment, sir.
Yes, no, I think it was a great save, great save. These patients, they do incredibly poorly. One comment about the subluxation of the mandible. Another option that has been described is to cut the angle of the mandible at the 90-degree to allow it to come back. All of these are done for elective surgeries when the carotid needs to be accessed for an endarterectomy. To do this in an emergency, I would say it's almost impossible. So if you cannot push the mandible forward acutely in a patient who is bleeding, you will not have time to do any of those other maneuvers. The mandible, surprisingly, can be subluxated by hand, relatively easy, might give you enough exposure, but that's probably all you're going to get. Otherwise, for emergency cases, you would not have the luxury of doing any of those. The other two things is, I was writing here in my notes, this patient probably aspirated a lot of blood, and some patients develop a very severe pneumonitis from blood aspiration. I think that was probably what was happening initially, besides abdominal compartment syndrome, for having those really bad ABGs. And sometimes they are very difficult to control medically with a respirator, and these patients might need to go on ECMO, which creates another problem because they need to be anticoagulated, probably not so much as they would need for an embolectomy. Embolectomies or any type of, like doing an open Trendelenburg procedure, the patient needs to go on bypass. They get 300 units per kilo of heparin. So it's really an operation of last resort. Some patient who had a massive pulmonary embolism and is hemodynamically unstable and maybe will survive with this. But those are kind of difficult options in patients like this when you are trying to balance that with the possibility of converting this in a hemorrhagic stroke. And finally, one thing that I am old and I have seen and done too many stupid things. I didn't do this, but I saw a partner of mine doing this. Did a cricothyroidotomy with a tracheostomy tube, and the tracheostomy tube went up through the vocal cords. And they found out that too late. So since I saw that happening, I do all my cricothyroidotomies with a regular tracheostomy tube because it's much easier to direct it downwards. I'm not saying that anytime that you use a tracheostomy and endotracheal tube, it will go upwards, but it's more difficult to secure anyway. So I prefer to use a tracheostomy tube for regular cricothyroidotomies. But I don't know, that's a bunch of ramblings and random comments. I really would like to congratulate you for an excellent case, an excellent outcome. I know it's sad what happened to the guy, but I would say 9 out of 10 times this patient will be dead and he's alive because of what you did. And I would like to congratulate you for that.
Thank you. I use the bougie actually, and I put the bougie down and then I put the AT tube over.
But thank you, Dr. Alex, for presenting, and thanks everyone for joining and participating. Don't know if Valeria has any comments or direction about next time.
Thank you, everyone. Now we'll send an email shortly.
Okay. All right, folks.
Bye-bye.
Thanks for joining again. Thanks again, Dr. Alex, for presenting. Take good care of yourselves. I look forward to seeing you next meeting.